and 45% of cellular elements. So kita ada about 1% white cells and platelets, and the rest are red blood cells. So for anemia, we will discuss mainly on red cells. Okay, so red cell is a non-nucleated cell. Kalau you tengok sel dia memang tak ada nucleus, it's all red in colour, biconcave. So that's why you nampak the center is pale, sebab dia biconcave, dia berlekuk di tengah dia. So that's why you have the central pallor. We call this a central pallor. And it is deformable. Dia boleh melipat so that it can pass through the small capillaries. And it composed of 45% of the total volume of blood. So this cell is a special cell with oxygen carrying capacity. Okay, if you look at the blood film, red cell will appear as a round cell with a central pallor. Kalau you tengok sini, the central pallor is about 1/3 of the diameter. Tengah-tengah tu saja, 1/3 of the diameter is the central pallor. And in the normal blood film, you will see about 1% of the total cell which stain purplish and have a larger size. For example, this one, dia lebih besar, and the color is purplish. Boleh beza tak? This is normal red cell. This is reticulocytes. Reticulocyte is the premature red cells. Why do you think it is purplish in color? Boleh tak dengar? Oxygen? What about oxygen? No oxygen? Low oxygen? You mean, okay, deoxygenated itself lah. Agree? Yang lain? Kenapa yang lain merah? Dia je purple. Kalau low oxygen, every red cell will be purplish.
Dia tak carry oksigen lagi.
Dia tak carry sebab dia premature. Actually, this cell is dia belum betul-betul mature. Dia still ada the nucleus punya remnants, the DNA strands. So that's why it gives the purplish color. So after some time dia akan hilang, akan jadi mature red cell, dia akan jadi red. The red color is the hemoglobin. Okay, and if you look at the blood film, you will see occasionally platelet macam ni. The small one is platelet. This is a lymphocyte. And also neutrophil. Ni semua you dah belajar kan, physiology, the morphology of other white blood cell. Okay, so in adults, the blood cells is produced in the red marrow. Where do you find red marrow? Mainly in the long bones, and also in the flat bones, the pelvic bone, the skull, you have the red marrow. Okay, so in the adult bone marrow, it consists of 50% of fat cells and 50% of blood cells precursor. So this is a normal adult marrow. You have the fat cells and also the hematopoietic precursor. This is megakaryocyte, the precursor for platelets. In pediatric bone marrow, you will have less fat cells, and in elderly, you will have more fat cells, because it becomes atrophic. So as I mentioned just now, other bones like facial bone and skull bone can also produce hematopoiesis when required. And liver and spleen can also be hematopoietic organs. So when you have hematopoiesis in this organ, you call it extramedullary hematopoiesis, which is not normal, pathological. It is a compensatory mechanism, but it should not happen in a normal person. So that's why sometimes in patient with hemato problem, you can have enlarged liver and spleen because of the extramedullary hematopoiesis. Nanti kita akan bincang lagi. Okay, so in the peripheral blood film, usually you will see only these mature red cells and the polychromatic cells or reticulocytes tadi kan. But in the marrow, you will see all this spectrum of maturation of red cells, starting from the blast until the mature red cells. So kalau you nampak these immature cells in the peripheral blood, it means there is something wrong with the marrow. Okay, kalau you nampak blast, in the peripheral blood, that means the marrow is having some problem. Okay, you sepatutnya nampak only these two stage of red cells. Yeah. The erythropoiesis, you dah belajar in physiology kan? What are the hormone that stimulates hematopoiesis?
Erythropoietin.
Erythropoietin. What stimulates erythropoietin production?
Low oxygen. Low oxygen.
Apa dia?
Low oxygen.
Low oxygen, yeah, hypoxia. So when your body sends hypoxia, erythropoietin will be produced by the kidney and liver, and it stimulates the bone marrow to produce more red cells. Yeah? So it maintains the equilibrium. Alright, now we go to anemia. So by definition, anemia is reduction in the hemoglobin concentration in the blood. So you look at the hemoglobin level to identify anemia. So it depends on the level lah. Male, female, newborn children will be different. But for a general definition of anemia, if it is less than 12.5 in adult, you consider as anemia. Yeah. So when you have anemia, it causes reduction in the oxygen transporting capacity of the blood. And anemia can be reflected in the full blood count by abnormal hemoglobin and also hematocrit. Okay, hematocrit tahu apa? Like cell volume and hematocrit are the same thing. The the red cell component in the blood. However, in certain conditions like reduced plasma volume in dehydration, it may mask the anemia. Okay, because you have less plasma when you have dehydration, and also when you have increased plasma volume, it may looks like anemia. For example, in pregnancy, your plasma volume is higher, so it looks like you are having anemia because it is diluted. Yeah? And in acute blood loss, anemia is not seen immediately unless you give intravenous fluid. Why do you think it is not seen immediately? What is the unit for hemoglobin?
Gram per liter.
Gram per
liter.
deciliter kan? So the gram of hemoglobin over the volume of the plasma. So kalau you bleed, acute blood loss, you lost the plasma as well as the red cells. So sebab tu dia tak detect. Unless you bagi fluid, it becomes diluted again, kan? Because plasma volume tu akan bertambah, then only you detect the anemia. Okay, now the classification of anemia. You can classify anemia based on the cause or based on the morphology of the red cells. Yeah? So if you look at the cause of anemia, you can classify it to anemia due to blood loss, anemia due to increased red cell destruction, or due to decreased red cell production. Yeah? And you can also classify based on the morphology. Biasanya in clinical we will use this classification. Sebab you buat blood film, you can straight away classify based on the morphology, and it correlates to the cause of anemia. So if you classify based on morphology, it can be hypochromic microcytic, macrocytic, or normochromic normocytic. So you look at the color and size of the red cells. Color, you call it chrome. So kalau hypochromic means
Low color.
the color is pale, low color. Microcytic,
Small.
small. So small and pale is hypochromic microcytic. Macrocytic, cells is large, and you can also have anemia with normal size and normal color of the cells. Okay, hypochromic microcytic anemia. The common causes are iron deficiency anemia, that is the most common. You can also have hypochromic microcytic anemia in thalassemia and hemoglobinopathy. In anemia of chronic disease, some cases, most of it are normochromic normocytic, tapi you can also have some cases with hypochromic microcytic. Sideroblastic anemia, this is rare, and also lead poisoning, which is also rare. So the most common are these three. Okay. Macrocytic anemia, The common causes are megaloblastic anemia. Dah pernah dengar kan dulu? Which is caused by B12 deficiency or folate deficiency. And you can have macrocytic anemia which is non-megaloblastic. So, you ada banyak causes of non-megaloblastic anemia. Contohnya alcoholism, liver disease, myxedema, patient on chemotherapy, aplastic anemia, pregnancy and a lot more. Okay. And normochromic normocytic anemia, it can be caused by hemolytic anemia. Most of the cases, they are normochromic normocytic. Anemia of chronic disease, as I mentioned just now. Acute blood loss. Mixed deficiencies, that means patient may have iron deficiency and folate deficiency, so it becomes normochromic. And it becomes normocytic. The chrome is sometimes low, tapi the size dia normal. And also bone marrow failure. Nanti akan belajar bone marrow failure in your SLP. And the morphological classification of anemia can be judged by visual inspection. You look at the blood film. Okay. And in the current full blood count machine, it can be measured objectively. Bila you tengok dekat full blood count punya results, you boleh nampak hemoglobin, red cell count, hematocrit, MCV, MCH. These are the parameters that is important. So hemoglobin, you look at the level. MCV, any idea what is MCV? MCV means cell volume. What does it indicate? Size. So you tengok dia punya MCV, compare with the blood film, tally atau tidak lah, the size. What about the MCH? It correlates with the colour, the hemoglobin content. So bila you tengok full blood count, these are the first thing that you should look for and classify the anemia. Okay. The clinical features will depend on speed of the anemia. Kalau you have rapid anemia, you will have more symptoms than slow onset. So patient will come with shortness of breath and lethargy. The slow onset anemia, for example, iron deficiency. I have one case when I was in hospital Kuala Lipis. We have a lot of orang asli there. A boy, I think about 12 years old, he walked from the jungle with hemoglobin of 5. Dia ada hookworm infestation, so he lost blood for some time, so iron deficiency. But he still can walk because it is slow onset. Dah bertahun-tahun dia ada that anemia, so the body adapt. And compared to sudden blood loss, dia akan ada shortness of breath and lethargy. And severity of anemia. Usually if it is more than 9, patient tak ada symptoms lah. If it is less than 9, they can have the symptoms like lethargy. Usually lethargy is the common symptom lah. And the age of the patient. Young patient will tolerate better compared to elderly. The other factor is the hemoglobin dissociation curve. It is better adapted in low affinity hemoglobin. You dah belajar kan physiology? Hemoglobin dissociation curve? Okay. So the general features, they can have pallor. Where do you look for pallor? Dah belajar ke clinical skill? Conjunctiva. Where else? Mana lagi? Dah belajar ke belum?
Dah.
Conjunctiva is the most common one. What else? Okay, palm. What else?
Mouth.
Tongue. Mucosal membrane in the mouth. The tongue and the lips. And patient may complain of lethargy and shortness of breath. Other features which are more specific. If you look at the blood count or blood film, patient will have reticulocytosis. Remember just now I said about only 1% reticulocytes in the normal blood film. So if patient is having acute bleeding or hemolysis, the reticulocyte count will go up. Okay, it will be raised. and it can raise by 5 to 8 times. Okay. And in certain condition, you may have reticulocytopenia. You tak nampak pun reticulocytes tu langsung. In case where you have decreased red cell production, for example, the bone marrow failure or severe folate deficiency. And you can have extramedullary hematopoiesis. What did we learn just now? Extramedullary hematopoiesis? Liver and spleen. So you will see enlarged liver and spleen where you have severe chronic anemia. So you will see hepatosplenomegaly and also thalassaemic cases. Pernah tengok thalassemia patient? Belum. Belum pergi hospital kan? They are a typical facial feature of thalassemia major. They call it thalassemia facies. Nanti I akan tunjuk gambar lah. Okay. So these are the special features in certain type of anemia, and this is the general one lah. All anemia will have these similar clinical features. Okay, now anemia due to blood loss. Chronic blood loss will induce anemia if the rate of loss is more than regenerative capacity, and it is usually not detected immediately unless it is very severe. And it takes about 5 days to see the reticulocytosis. Dia tak immediate lah, hari ni bleed, hari ni reticulocyte increase kan, because your body needs some time to react kan. And in acute case, acute blood loss, the immediate threat is hypovolemic shock. We are more worried of hypovolemic shock, but not the anemia. Patient boleh mati because of the hypovolemic shock, but not because of the anemia. Okay. So in chronic blood loss, we will have iron store depletion, and patient will have iron deficiency anemia. Macam yang kita tadi lah, yang infestation tadi kan, the loss blood together with the iron. If you have blood loss internally, for example, you have hematoma, big hematoma, it is internal bleeding, your body will recapture the iron. So you tak ada iron deficiency anemia lah, because you recycle the iron. For example, if you have hematoma or hemolysis. Okay. Now ini is only if you lost externally. Okay. Clear ke so far? Okay. Now anemia of decreased red cell production. It is due to inadequate supply of substance which is necessary for hemopoiesis. So the most common are iron, folic acid and B12. And other important causes that cause decreased production is aplastic anemia. Dah ada SLP ke? On bone marrow failure?
Dah.
Belum. Nanti you akan dapat the input from the SLP. It can be aplastic anemia or bone marrow infiltration by malignant cells. Okay. You can see this anemia due to marrow infiltration in leukemia, lymphoma, and also solid tumors. For example, if you have a case of breast cancer, the malignant cells can infiltrate the marrow, occupy the marrow, and it reduces the hemopoiesis. So the bone marrow will fail and patient will have severe anemia. Okay, now we look at the most common cause of anemia, iron deficiency anemia. This is the most common nutritional anemia, and the prevalence is about 10% in developed countries and about 25 to 50% in the developing countries. I did a study a few years back among the medical students, the female medical students. It's about 45% is iron deficient. Female lah, I ambil female specifically because males usually they don't lose blood kan. The females are losing blood kan. So it's actually quite high in our population. And iron storage pool is usually in the form of hemosiderin and ferritin bound iron. It's about 15 to 25% of the total body iron. And about 80% of the functional body iron is in the hemoglobin. Okay. We also have iron in myoglobin and other functions, but mostly is in the hemoglobin. So iron is transported in plasma by a protein called transferrin. It will bind iron and transport iron from the cell to the plasma. And the storage site for iron is in the liver, spleen, marrow and skeletal muscle. And for investigation, serum ferritin is a good indicator of iron store. Okay, nanti kita akan tengok the metabolism dan kita fahamlah. So normally transferrin is about 1/3 saturated, about 33% saturated, and another 2/3 is free. And total iron binding capacity is 300 to 350 microgram. The iron balance is maintained by regulating the absorption of dietary iron. Your punya source is mainly from diet, and you don't have any regulated pathway for iron excretion. It is mainly lost by shedding of the mucosa. Sebab ferritin tu akan disimpan dalam mucosa, and when you have shedding, you will lose your iron. Okay, in normal Western diet, we have about 10 to 20 milligram of iron, which is sufficient to balance the fixed daily iron loss. Your iron source in the body is mainly from the recycling of the iron in the body. You tahu kan red cell you akan destroyed after berapa hari? Lifespan of the red cell 120 days. So dah 120 days, the red cell will be destroyed. So you recapture balik iron tu, guna balik untuk hematopoiesis. But you also need from the diet to balance the daily iron loss. But you lost juga kan from the epithelium. And this is the Western diet. Iron dia mainly in the meat lah. Not Malaysian diet. You rasa cukup tak iron ni?
Cukup.
What are the source of iron in your diet?
Red meat.
Red meat. Breakfast you makan nasi lemak, tak ada red meat. Roti canai tak ada red meat.
Daging.
Banyak juga in eggs, in leafy vegetables. Tapi tak banyak lah, because iron you can classify it in the form of heme or non-heme. Heme mainly in the meat lah, meat, seafood, fish. And the non-heme is in the vegetable and nuts mainly. So kita maybe kurang lah in the heme iron kan kita punya diet, unless you memang betul-betul makan protein lah for your diet. So you have to be careful with your diet juga. Okay, so about the metabolism, the mechanism, dah belajar ke iron metabolism masa disability?
Sama sikit tu.
Okay, so the mechanism of heme iron absorption is not well understood. Tapi heme iron yang sebenarnya banyak dalam badan kita, tapi the mechanism is still unclear. So it is absorbed in the duodenum, and it pass through the apical and basolateral membrane of the enterocytes. This is the enterocyte, the mucosal lining in your duodenum. So it is absorbed through a receptor at the apical membrane, which is known as DMT1, and it is then digested by heme oxygenase, and some will be transported to the plasma, some will be stored as ferritin dalam you punya epithelium. So kalau epithelium ni shed, then you will lose your iron from the ferritin that is stored there. Okay. For the non-heme iron metabolism, it is clearer. So your iron in the diet is usually in the form of ferrin, Fe3+. So it needs to be reduced to Fe2+ by duodenal cytochrome B, which is a ferrin reductase. So dia perlu di reduce and then carried by DMT1 ni lah, transporter. Moves across the membrane, sama juga macam non-heme tadi, will be digested, and some will be stored as the ferritin, some will be transported by the ferroportin. They can pass through this basolateral membrane and will be transferred to the portal plasma for your functional use lah. Dia akan dibawa ke marrow untuk proses dan sebagainya. Okay. And iron export is controlled by hepcidin. Hepcidin is a protein here. If you have low iron, for example in iron deficiency, the ferroportin will be high, so more iron will go to the circulation. If you have enough iron or excess iron, the ferroportin will be low, so that it will be stored in the cell as ferritin. Dia akan simpan sebagai storage saja. And then just now kita bawa masuk in the Fe2 plus kan, it needs to be converted again to ferric Fe3 plus, so you need heptestin to transform this before binding to transferrin and goes to the plasma. Okay, so the important protein in iron metabolism is DMT1, hepcidin, ferroprotein and heptestin. So only a proportion of iron which is absorbed in the erythrocytes will be delivered to the plasma. Some will be bound to the mucosal ferritin and lost to the exfoliation. And if body iron is adequate, iron bound to mucosal ferritin will be lost. And in iron deficiency, iron bound to mucosal ferritin is transferred to the plasma. So that's how you maintain the iron balance in the body. So the causes of iron deficiency anemia, mostly it is due to the dietary inadequacy. Contohnya vegetarian. Vegetarian dia adalah non-heme iron, tapi the amount that is absorbed is very low kan. So that's why they have iron deficiency anemia. And also commonly seen in elderly because they have poor appetite, so dia tak dapat banyak iron intake. And that's why it is rare in developed countries. Developed countries ni dia makan protein banyak, and sometimes dia also ada supplement, iron fortified milks, cereals kan, semua dah iron fortified kan sekarang. You tengok macam Coco Crunch apa semua tu, all are iron fortified. The second one is malabsorption. Patient with celiac disease or tropical flu, they have problem with absorption, so they have iron deficiency anemia. If you have increased demand, for example in pregnancy, because you need to supply the iron to the fetus as well, so you lost your iron to the fetus. Lactating mother, infancy and adolescent, because they are growing. They are having increased demand, so kalau dia tak cukup intake, they will have problem of deficiency. And also chronic blood loss. For example, patient with peptic ulcer disease, with hookworm infestation, or ladies with menorrhagia, heavy menses. So these are important. Bila you nak ambil history of iron deficiency anemia, you need to ask all this, especially the important one is in the dietary intake, because that is the most common cause. So features of iron deficiency, regardless of the cause, it will develop slowly in 3 stages. First, you have depletion of iron store. You akan nampak low serum ferritin, low stainable iron in the bone marrow. Then it progress to decrease in iron in the circulation. So you will have low serum iron and raised TIBC, total iron binding capacity. And the last stage is iron deficiency anemia. Then only you will see low hemoglobin. Okay. Mula-mula dia tak anemic pun. Only the store ni yang nampak kurang lah because you will use up all your storage before it becomes anemic. So other features, low hemoglobin level, usually not severe. Iron deficiency jaranglah yang severe unless it is continuously losing. Hypochromic microcytic red cells, and usually it is associated with thrombocytosis. We are not sure what causes the thrombocytosis, but it usually comes in association. When you have iron deficiency anemia, you have thrombocytosis, raised platelet counts. And you don't have extramedullary hemopoiesis in iron deficiency anemia because it is not severe enough to cause extramedullary hemopoiesis. They can have atrophic glossitis and angular stomatitis. I will show the picture. They can have dysphagia. You know what dysphagia is? Difficulty in swallowing, because usually they will have esophageal web. They call it Plummer-Vinson syndrome. But this is not common. Occasionally you may see. Most patients are asymptomatic. They don't have any symptom. But in severe cases, they will complain of lethargy, weakness and pallor. In long-standing severe iron deficiency anemia, they can have koilonychia. You look at the fingernails, it is thin, fragile, flattened, and spooning. You punya kan curve kan? It become flat and spooning. Lekuk macam tu. Yeah? This is the picture. And in certain condition, they can have pica, which is craving for non-food stuff. Yeah? For example, dia rasa nak makan clay, dia rasa nak makan beras. This is, I associate this with mengidam in pregnant lady. Kan dia suka makan pelik-pelik. So that might be pica lah. And deficiency in pregnancy. Okay, so this is koilonychia. Boleh nampak ke? Kuku dia. Kukuknya tu ya. So this is koilonychia. This is atrophic glossitis. Dia nampak raw The tongue looks raw. And you have lesion at the angle of the mouth. That is angular stomatitis. And this is the esophageal web. You nampak macam ada stricture at the esophagus. Ni dia buat barium study lah. Okay, so for the investigation, you look at the blood film. Macam kita mention tadi, low HB, low hematocrit, low MCV, low MCH. And if you look at the blood film, there are specific cells that you should be able to identify. Hypochromic microtubule cells, pencil cell, and target cell. I will show later. You look at the serum ferritin, it will be low. Serum iron will be low. TIBC will be increased. Kalau you measure serum iron, you can measure together with the TIBC. Sebab kalau you buat iron saja, it is meaningless. Why?
Sebab
Pernah dengar acute phase protein in inflammation? Iron is an acute phase protein. So if you have inflammation or infection, your iron will raise. So you can have a false negative. So sepatutnya you kena buat iron and TIBC. TIBC is the capacity of the protein to bind to iron. So it will be high sebab you tak ada iron, so the protein is free. Dia ada banyak capacity untuk bind. So sepatutnya iron low, TIBC high. You nampak tak? And you look at the bone marrow, it will show low or absent iron store. And if you give iron therapy, patient will give a good response. So bone marrow is the gold standard lah sebenarnya. Tapi we don't usually do bone marrow to diagnose iron deficiency. Sebab this is invasive kan. Bone marrow aspiration is invasive. So enough with this to diagnose IDA. It's not mandatory. Tapi kalau you buat bone marrow tu, you assess lah terus iron. Sebab you dah ada sampel kan. Kalau you buat marrow untuk other causes lah, for example leukemia ke lymphoma ke kan, you buat juga lah for the iron store. Okay, this is about the TIBC. So TIBC is referring to the capacity of the transferrin to bind iron. So in normal condition, you have about 1/3 of the transferrin bind to iron. Sepatutnya about this lah, 1/3 bind to iron, about 2/3 is still free. So this is the total iron binding capacity. This is the total, this is the free one, iron binding capacity. So in iron overload, the liver produce less transferrin and more ferritin to increase iron loss. But you dah banyak iron kan, you nak buang lah. Sebab iron overload is also not good, it's a pathological condition, it can be toxic. In iron deficiency and pregnancy, the liver produce more transferrin to maximize the use of iron available. Sebab you tak cukup iron, you need to transfer the iron keluar kan. So you akan produce more transferrin. In anemia of chronic disease, the liver produce less transferrin but more ferritin to keep iron away from infective agents. Okay, this is the blood film of IDA. This is the normal one. Pernah tengok kan masa fisio? These are the red cells, but 1/3 is central pallor. This is a apa ni?
Reticulus.
This is a normal lymphocyte. Biasanya kalau you nak tengok blood film, you kena compare the size of the red cells to a normal lymphocyte. The diameter should be about the same, normal lymphocyte and red cells about the same kan, size dia tak banyak beza kan. So you selalu compare this as a standard. So this is a normal blood film, and this is the iron deficiency blood film. Boleh nampak beza tak? If you look at the red cells, apa yang boleh nampak kat sini? Yang you boleh identify?
Central pallor is bigger. Bigger central pallor.
Central pallor dia besar kan? Dia merah dia tu, rim dia very thin. Betul? So this is hypochromic tapi tak ada lymphocyte untuk kita compare the size So you kena tengok to the full blood count lah. And this is pencil cell. It is elongated, nampak macam pencil. So this is typical of iron deficiency anemia. What about this cell? Anything special about this? Nampak tak? Nampak kat tengah-tengah dia ada apa?
Ada.
Dia ada central pallor, a large central pallor. Nampak tak kat tengah-tengah dia tu ada apa? Dia tak clear betul macam sel ni kan? Kalau you tengok sel ni, tengah-tengah dia clear, pale saja kan? Sini macam ada red dot kan? So this is what you call target cell. Kat tengah-tengah dia tu macam ada target. Why do you have target cell? When the volume is very small, dia punya membrane tu touch each other, atas dengan bawah tu touch. So dia nampak macam target. Dia jadi dark colour sikit kat tengah dia tu. You can see target cell occasionally in IDA. Dia tak banyak sangat lah compared to in thalassemia nanti. Okay, boleh identify? Ini biasa kita tanya because this is important for you to be able to diagnose from the blood film. Okay, the practical kita tengok lagi. Okay, if you look at the bone marrow, this is a gold standard assessment of iron store. You use the pearl stain, Prussian blue color, and these are the iron store yang biru-biru ni. This is macrophage containing iron in the bone marrow, and this is the case of iron deficiency anemia. You tak nampak langsung any blue color. There is absence of iron store in the marrow. Okay, clear with the iron deficiency? Okay, we can move to megaloblastic anemia. So, by definition, it is anemia with large red cells due to inhibition of DNA synthesis during hemopoiesis. So, in megaloblastic anemia, the nucleus maturation is delayed compared to cytoplasm. And the common causes are due to deficiency of folate and B12, and it is related to nutritional deficiency, impaired absorption and increased demand. Lebih kurang sama je dengan iron tadi. So the pathogenesis, the underlying defect is asynchronous maturation of the nucleus. Cytoplasm mature but nucleus delayed due to defective in DNA synthesis. So these abnormal cells which are large are prone to premature destruction by the phagocytic system. And not only the red cell is affected, the white cell and platelet is also affected. Because megakaryocyte and white cell precursors pun ada nucleus kan. So all cell lines are affected. So they don't only have anemia but pancytopenia. Semua low. White cell low, platelet low, red cell low. So you have maturation derangement, defect in DNA synthesis. This abnormal cell will be apoptosis in the marrow. Dia tak sempat keluar pun. Dia akan apoptotic in the marrow, and you call this ineffective hematopoiesis. Dia ada hematopoiesis tapi tak efektif, tak sempat mature. And you will have total output diminished and you have pancytopenia. Okay, if you look at the blood film, the earliest changes in blood film is hypersegmented neutrophils. Even before you have anemia, you dah ada this hypersegmented neutrophils. Biasanya berapa lobe you nampak?
3
3
2
to 3 to 5. Normal is 3 to 5. lobes of neutrophil punya nucleus, but here you have more kan, so that's why you call it hypersegmented neutrophil. And the red cells are typically large and oval, so you call it macrocytes. And you may see large platelets, sebab platelets pun affected juga. Okay, boleh identify hypersegmented neutrophils is important. Okay, if you look at the bone marrow, there will be marked hypercellular. Sel sangat padat, banyak sel, because your body is anemic, so the body is trying to produce more cells. So it will be hypercellular, and you will see megaloblasts. So these are megaloblasts. So the features, it is large than normal normoblasts, and if you look at the nucleus, it will have delicate, finely reticulated nuclear chromatin. Dia nampak macam berjaring. Kalau you tengok this normal normoblast, padat kan dia punya nucleus. Yang ini you nampak macam berlubang-lubang. So that is megaloblast. This is just for your knowledge lah, to understand what is megaloblast. You are not expected to be able to identify marrow lah, in the marrow. The blood film tadi you kena able to identify, but not the marrow. Okay, now the cause can be folate deficiency, which is associated with poor diet and increased metabolic needs. So the source of folate is from fruits and also vegetable, and it should be uncooked or lightly cooked. So elok makan ulam lah, high in folate, and it is destroyed by cooking. So the absorption is in the 1/3 of the small intestine. And if you take this food together with acidic food and legumes, it will reduce the absorption. And some drugs may also inhibit the absorption. Okay, the causes of deficiency can be due to poor intake, malabsorption, increased demand, mixed causes, and also some drugs. Ni dah belajar kan folate metabolism? Dah belajar biochem?
Tidak.
Dah kan, saya tak payah explain detail, tak cukup masa tau. So you need this folate here. It is in the form of tetrahydrofolate. So you need tetrahydrofolate for the building block of the DNA. So bila you ada defect kat sini, deficient dekat sini, you will have problem with the DNA formation. So that's why you will have the delayed maturation. Okay, the details nanti you baca balik nota lama. Nampak ni. Clinical features, you will have patient will have anemia, usually slow onset. So features dia samalah, complain dia weakness, fatigue, and it may be complicated by other deficiency, especially kalau patient tu alcoholic, dia akan ada other deficiency also, and dia pun akan ada sore tongue juga macam tadi, glossitis and angular stomatitis. And in folate deficiency, they don't have neurological abnormalities. So the diagnosis, tengok blood film tadi, macrocytic cells with hypersegmented neutrophil. Bone marrow, you will see megaloblastic anemia, and you have to measure the folate level. It will be low, and usually the B12 is normal. Okay. If it is due to B12 deficiency, it also results in megaloblastic anemia, but it is associated with demyelinating disorder. We call it subacute combined degeneration, which involve peripheral nerve and spinal cord. Ni pun dah belajar kan? CNS. Belajar tak? Okay, whatever it is, megaloblastic anemia, common cause is folate and B12. Folate, you don't have the CNS features, but B12 you will have these neurological symptoms. And another common cause of B12 deficiency is pernicious anemia. Dah belajar kan pernicious anemia? Dah tengok your PBL package, ada kan? Okay. So causes of malabsorption, causes are mainly due to malabsorption of B12. So it's important for you to ask for this, history of gastrectomy, resection of the ileum, because in gastrectomy, they will lose the intrinsic factor producing cells. Nak dengar intrinsic factor? Kan? So kalau gastrectomy, they have risk of B12 deficiency. and also ileum, that is the site of absorption. If you have other disease of the distal ileum, for example, Whipple disease and tropical sprue, they will also have malabsorption. And in old age, they can have gastric atrophy, and they will have reduced production of the hydrochloric acid, and without this, B12 will not be released from the diet. Okay, B12 absorption dah belajar kan? Perlu ulang ke? Tak perlu Okay, so the important thing is that you need the gastric parietal cell to produce the intrinsic factor. Okay, you need intrinsic factor to carry the B12. Okay, tengok slide sini, you boleh study balik lah physiology. Okay, in pernicious anemia, normally you will have the parietal cell in the gastric that produce acid and intrinsic factor. So in pernicious anemia, you have atrophic gastritis. It is atrophic, so it does not produce enough hydrochloric acid and intrinsic factor. So that's why you have the pernicious anemia. It is usually caused by autoimmune reaction that goes against the parietal cell or against the intrinsic factor itself. Okay, so it produces gastric atrophy, and you will have reduced acid and intrinsic factor production. And you can diagnose this by looking at the serum and gastric juice for the autoantibodies. You detect the autoantibodies in the serum or the gastric juice. Okay, it is usually associated with female, usually in Caucasian lah, Mak Saleh, early graying, blue eyes, mainly in Northern Europe, and it is familial, blood group A and diabetes mellitus, because diabetes can also associated with autoimmune, and it is also associated with other autoimmune diseases like vitiligo, myxedema, Hashimoto, thyrotoxicosis, epicensis, and a long list lah actually. Ini pun dah belajar kot. Gambar yang sama dengan yang tadi, So you require B12 here to transform the methyl tetrahydrofolate to tetrahydrofolate. So you will need B12 here. Okay, so kalau you tak cukup B12 here, you will also affect the DNA maturation. Okay. The clinical features lebih kurang sama, cuma dia ada the neurological lesion, which is the subacute combined degeneration, and they can also have mild jaundice due to destruction of cells in the bone marrow. GIT symptoms lebih kurang sama dengan folate deficiency, and you have to be careful. Kalau you ada megaloblastic anemia, you have to identify whether it is B12 or folate deficiency. You jangan bagi folate sebelum you dapat the diagnosis, because you need B12 untuk nak maturkan the folate kan. So kalau you bagi more folate, dia akan use up all the B12 yang ada tu, and it becomes more severe. Okay, so you have to establish your diagnosis first. And it is the severity is not related to the degree of anemia. And if you give parenteral B12, injection B12, they will respond well. Okay, subacute combined degeneration is a progressive neuropathy which affects the peripheral nerves and spinal cord, and the pathogenesis is due to reduced methylation of neuronal lipids and proteins, and it leads to demyelination. Pernah dengar kan demyelination dulu? Okay, so the symptoms, patient complain of pain, numbness and tingling sensation in the hands and feet. Dia rasa macam cucuk-cucuk dekat hujung kaki dan tangan, and they have difficulty in walking and fall in the dark. Sebab dia ganggu dia punya balance juga. And usually it is symmetrical, left and right sama, and lower limb is more affected than the upper limb. You can also have optic atrophy and psychiatric symptoms like depression. So the diagnosis, you look at the blood film, look for the features of megaloblastic anemia, and serum B12 will be low, folate may be normal or elevated, and you may detect presence of anti-intrinsic factor of parietal cells. And there is a specific test for pernicious anemia. You call it Schilling test, nanti I akan tunjuk. And if you give parenteral B12, they will show good response. So Schilling test is a test to diagnose pernicious anemia. Ni teori is important for you, but in clinical dah tak buat dah Schilling test ni sebab dah ada more sophisticated test tapi the theory is important for you to understand. So Schilling test dia ada dua part. Part 1, you ask the patient to fast, puasa 10 to 12 hours, and then ask them to drink radio label B12, B12 yang you dah labelkan, and give intramuscular vitamin B12 which is unlabeled. Yang minum label, yang inject unlabeled. Okay, and you measure the radio label B12 in the urine in the first 24 hours. So if it is more than 5%, it is normal, and if it is less than 5%, it is abnormal. Boleh faham tak konsep dia? Sepatutnya you should absorb apa yang you makan about 5%. Yang tu yang you dah labelkan tadi kan. So kalau less than 5%, maksudnya tak cukup kan absorption dia. Okay. So kalau abnormal, you proceed with the part 2. Repeat the test together with oral intrinsic factor. Tadi B12 saja without intrinsic factor. Now you bagi intrinsic factor. If it normalize, it is pernicious anemia. If it remains low, it is malabsorption. Nampak tak? Okay. Maksudnya dia ada problem with the intrinsic factor lah. Kan? Bila you bagi together, absorption is okay. Kan? So it is currently not routinely done, tapi important for you to understand what is happening lah. Yeah. Okay, now the last one, anemia of chronic disease. So this is the most common type of anemia in long-standing hospitalized patient. Yeah. The causes can be due to chronic microbial infection, for example osteomyelitis. Tahu osteomyelitis apa? Infection of the bone. Yeah. Usually osteomyelitis ni dia susah nak heal because difficult for the antibiotic to penetrate into the bone. Endocarditis, infection of the endocardium, and also lung abscess. Abscess are also chronic infection. Biasanya it can cause chronic anemia of chronic disease. Chronic immune disorders, for example rheumatoid arthritis, SLE, and also malignancy like lymphoma, lung and breast carcinoma. They can have anemia of chronic disease. So usually it is normochromic normocytic, and they have low serum iron and TIBC. Kalau IDA tadi low iron, high TIBC kan? Jadi both are low. Normal or raised serum ferritin and normal or raised marrow iron store. Okay. So the pathogenesis, it is related to decreased iron release from macrophage to plasma, and it can be treated by treating the underlying disease. We tak payah bagi iron, we treat the underlying disease because that is causing the anemia. And it does not respond to iron therapy. Sebab patient ada iron, cuma dia tak release, dia simpan dalam sel. So the possible mechanism is due to raised serum hepcidin. Ingat tadi hepcidin dekat the basolateral membrane tu, dia yang control kan, sama ada iron tu stay in the cell or goes to the plasma. So when you have raised hepcidin, dia akan block transfer from cell to plasma. So iron simpan dalam cell. That's why iron store you normal. Serum iron yang low. Okay. And it can be also due to reduced red cell lifespan. They have apoptosis in the bone marrow, and also inadequate or blunted erythropoietin response to anemia caused by cytokines. Because when you have chronic infection, you will have a lot of interleukins, CNF, prostaglandin and all that. That will cause blunted EPO response. Okay, so these are three possible mechanisms why you have anemia of chronic disease. Next is sideroblastic anemia. You boleh baca sendiri, not very common, but the features is you will see the in the marrow, the hemosiderin is around the nucleus. Dia duduk di keliling nucleus. That is how you diagnose sideroblastic anemia. You call this you call this ring as ring sideroblast. But this is just for your knowledge lah, tak important sangat. Jarang berlaku. Saya pun tak jumpa lagi kes ni. Okay, you pakai buku apa untuk hemato? Robbins ada hemato punya chapter. Tapi it's good if you can go and look for this book in the library. Kita ada a few copies. This is a book, a small book, specific for hemato. Yeah, because hemato is more clinical lah compared to pato. So you tengok diagnosis dia pun banyak clinical kan. It's not like kena buat biopsy, only the marrow lah. So it's good kalau you boleh dapat the copy from the library. Okay, that's all for anemia 1. Boleh break dulu.